Intervention Society conference. Here are my disclosures. So I'd like to review in the next 10 minutes a quick review of the bicuspid TAVR data, discuss some of the low-risk bicuspid results, talk about how to decide which bicuspid patients can benefit from a TAVR, review the impact of calcium distribution in bicuspid patients, and discuss some of the nuances around bicuspid sizing for transcatheter aortic valve replacement. So bicuspid aortic valve disease, as I think we all know, affects patients when they tend to be younger. And as TAVR has moved into a younger patient population, we're seeing bicuspid aortic valve disease more and more frequently. In fact, bicuspid aortic valve stenosis or regurgitation is the most common reason that patients undergo aortic valve replacement who are less than 70 years of age. I think most of us are familiar with the Sievers classification system. I think it is important to note that this where we see Sievers type 0 or type 1 actually does depend about a fair amount about where we are. In European populations, type 1 is the most common with left to right fusion. In Asian population, type 0 is more common. And the fact of the matter is that, early studies of patients with bicuspid aortic valves undergoing TAVR using primarily early generation valves demonstrated not very great results. Device success was lower, there was increased incidence of stroke, there was increased paravalvular leak, increased need for a second valve, as compared to patients with trileaflet aortic stenosis undergoing transcatheter aortic valve replacement. But this was with early generation valves, and certainly a lot of the modifications that have been made to the current generation devices have addressed a lot of these issues. And in fact, recent retrospective data has demonstrated that patients with bicuspid valves who undergo TAVR with current generation valves have outcomes similar to that to match patients with trileaflet valves. I've done a fair amount of work in this area. Here's some work that we've done from the TVT registry showing that in matched cohorts, bicuspid versus trileaflet valves, very similar outcomes for all-cause mortality. And when you look at paravalvular leak, again, very similar outcomes. Similar data has been done with the SAPIEN 3 valves, looking at the STS and ACC registry, following these patients out for a year. In this case, we have about 7,000 patients in the bicuspid group, and you can see there, outcomes in bicuspid and trileaflet valves undergoing TAVR very, very similar. It's important to note that for low-risk patients, there hasn't been an indication. So this is really for intermediate and high-risk patients, which led to some of the low-risk data. So what about the outcomes in low-risk patients? Well, this was data from Matt Williams presented at TVT, which demonstrated in their low-risk trial with the SAPIEN 3 valve that for patients who had a bicuspid valve as compared to a matched cohort from the SAPIEN or for the PARTNER 3 low-risk trial for a trileaflet valve, outcomes very, very similar as it related to death, stroke, rehospitalization, or the need for a new pacemaker. And we see similar data from that when we look at self-expanding valves showing really no significant difference between bicuspid and trileaflet patients undergoing transcatheter aortic valve replacement at 30 days or at 1 year. What about in terms of paravalvular leak by Sievers classification? This has certainly been an area of interest. And I think what we can see here is that in fact, type 0 bicuspid valves don't tend to be associated with worse outcomes. You can see here type 0 versus type 1. And in fact, if anything, although the numbers are small here, right, only 13 patients with a type 0. Study was done in North America where we have a lower number of type 0s as opposed to elsewhere in the world. Patients did very well, very little paravalvular leak. I think it's always important to look at the patients in these studies who screened out, who weren't included. And when you look at the patients from the bicuspid low risk study that weren't included, you see there were 60 patients that screened out. The majority of those were for anatomical reasons. 17 of them actually had a trileaflet valve when you looked at the CT scan. 15 of them had an aortic annulus that was either too large or too small for the commercially available valves. 9 of them had an ascending aorta greater than 4.5 centimeters, which is an indication for surgery. And in fact, only 1 of them had prohibited leaflet calcification. And I think this is a really important thing because the reason that patients didn't fail out for leaflet calcification is probably because they weren't submitted to begin with. And why is that? Well, the fact of the matter is that we know that calcium location and characterization can predict complications. We know that the location may predict how much regurgitation you're going to get, the potential need for a pacemaker. Calcium at the commissures can cause perforations. Calcium at the tips of the leaflets can risk coronary obstruction. And in fact, there's been some really nice work done by Yoon and Raj Makkar looking at just this. And so if you break patients down by their calcification when they have bicuspid valves, so if you break them down to look at the patients who have either excess calcium, a calcified raphe or excess leaflet calcium, or not a significant amount of calcification, what you'll see is that there's a significant difference in all-cause mortality out to several years. You can see here that at 2 years, in the patients who have excess calcium, their mortality is over 25%. And it's also important to note that about 25% of your bicuspid patients will have this. And so I think it's fair to say that one should expect when you're looking at your low risk patients that about 25% of patients will have excess leaflet calcification. That's associated with worse outcomes. Those patients weren't put forward in this study because the institutions knew this data. And so it's important to note that when we're looking at bicuspid data, that this includes a proportion of patients that were felt to have suitable anatomy. And I think, can more and more now understand what suitable anatomy is. And this excess calcification along the raphe is absolutely not suitable anatomy. So the next question that comes is, how do we size bicuspid valves? We're used to sizing trileaflet valves at the annular level, but there's been a lot of question about using supraannular measurements to size these. And if supraannular, where supraannular should we size these? This has been refined a little bit more, and I think it helps to think about what is the size at the level of the annulus and what is the size above that at the level of the orifice. And there are 3 different characteristics you can have. You can have sort of a tube-based, where the measurement at the annulus matches the level of the orifice, in which case it makes sense to do annular sizing. You can have this flare, where the size of the orifice is larger than the size of the annulus. And in this case, it again makes sense to do annular sizing. But probably somewhere around 10% or a little more than 10% of patients will have an annulus that's significantly larger than the opening of the orifice. And it's in these patients that supraannular sizing may be helpful. So how do we do supraannular sizing and how does it work? Well, Edwards has very nicely developed the circle method, which uses a multiplanar CT, where circles or ellipses in equal diameter to the valve that's going to be implanted are projected in multiple planes, starting at the annular plane and working up every 3 millimeters all the way up to the sinotubular junction. Each circle demonstrates the valve and the relationship to the anatomy that's there, and this is actually nicely reproducible. And the primary questions that this is trying to answer is the circle too large of the valve? Does it extend beyond the commissures? Is it large enough so that it touches it? And is it going to risk paravalvular leak or embolization? Or on the other hand, is it going to risk possible annular rupture or other disruption of the aorta? Here's just a nice example showing starting at the annulus and working up by 3 millimeter increments. Here, what we're looking for is how is the sealing taking place? What's the interaction between the SAPIEN 3 valve and the leaflets? And what can we expect there? It's also important, however, that we go up further from 12 millimeters to the sinotubular junction. Here, looking at interaction with the coronaries, the leaflet heights, and the characteristics there. I want to show just a nice example here. So here's a patient whose annulus measures 546 millimeters. It's really right on that border between a 26 and a 29 SAPIEN 3 valve. If you look down into the LVOT, it gets bigger. And so if this was a tri-leaflet valve, you might say, you know what, let's go with the 29 here. But this is one of the cases where really using this circle method is going to be helpful. And if you look here, as we scroll up and we have implanted here a 26 millimeter valve and a 29 millimeter valve, you can appreciate that while the 26 fits nicely in here and is going to work well. As we scroll up, this 29 millimeter valve really extends beyond the level of these leaflets here. And with this bulky calcification, you're probably going to risk annular rupture or other issues. And so this is a case where as we scroll up and we realize that it actually gets smaller up there, that sizing down to a 26 millimeter valve is going to be what's indicated. So in conclusion, for TAVR and bicuspid valves, I think it's critical that vigilant case planning with a focus on the CTA is done for all patients. It's important that we undertake shared decision-making with our patients, recognizing both that there's excellent data in bicuspid patients, including low-risk patients, but there are limitations to this data. Some of the limitations include the fact that patients who had unfavorable TAVR anatomy weren't included. So if you see a patient, they want to have a TAVR like so many of our patients do, but their anatomy shows that bulky calcified raphe. That's unfavorable anatomy. We know we're not going to get as good results, and those are patients that should be probably pushed towards surgery. I think it's also important to note that we don't yet have long-term data for these low-risk patients. So while we certainly hope and while other data from tri-leaflet patients suggest that these valves are going to last just as long, if not longer, than surgical valves, that true data isn't out yet for bicuspid patients. I didn't talk much about this, but I think if you are using cerebral embolic protection, bicuspid patients may be a group to consider. There has been some data that suggested that there's slightly increased risk of stroke in this patient population. I think it's critically important for these cases. They're low risk, they're bicuspid. There's a lot to be thinking about, that you use a valve that you're comfortable with. You take into consideration issues around the anatomy, the calcium distribution, hemodynamics, as well as the ease of coronary reaccess. And I think in the end, it's likely not going to be the number of leaflets that there. We can't just look at, okay, this is a bicuspid or this is a tri-leaflet valve, but rather the distribution of calcium. That, combined with proper planning and execution of the case, that will ultimately impact your results and lead to the best outcomes for patients. So thank you very much for this opportunity to talk.